Hello and welcome to today's webinar on looking forward, examining long-term services and supports integration and opportunities to strengthen coordination under CalAIM, made possible by the California Healthcare Foundation. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and the slides and recording will be posted on CHCF's website. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I'll now turn the webinar over to Alex Cruz, Associate Director at the Center for Healthcare Strategies.
Thank you, Travis, and welcome. My name is Alexandra Cruz. I'm the Associate Director, as Travis said, for Integrated Care here at CHCS, and we are very pleased to be welcoming you to this webinar today. Today's webinar is made possible by the support of the California Healthcare Foundation in partnership with the Center for Healthcare Strategies, or CHCS, and Chapman Consulting. In a moment, we will hear from Kate Myers, who is a Senior Program Officer at the California Healthcare Foundation, who will provide some helpful framing on their support for the webinar today, along with a related and recently released CHCF issue brief entitled Meeting the Moment, Strengthening Managed Care's Capacity to Serve Seniors and Persons with Disabilities. That was actually published last month and is available on the CHCF website today. The issue brief and today's webinar were developed to highlight some of the understood landscape challenges, potential success factors, and likely areas for future MCP capacity building. And the brief was actually informed by a series of interviews with managed care plans, Medi-Cal MCPs, and other relevant stakeholders that occurred last year in August of 2020. The team you see here contributed on the slide, contributed to the recently released issue brief and today's webinar. And so I'm pleased to introduce the rest of the team, which includes Athena Chapman of Chapman Consulting, who has been a key partner on this project, as well as my CHCS colleague, Giselle Toralba, who was a lead contributor to the development of the issue brief. Both Giselle and Athena will be contributing to facilitating today's webinar as we make our way through the agenda. Next slide, please. So today's webinar would not be possible, of course, without the generosity of time and support offered by the speakers that we'll be hearing from shortly. We're really pleased to have a variety of LTSS focused and Medi-Cal managed care voices or perspectives joining. Our LTSS panelists today will include Dustin Harper, the Chief Strategy Officer at Institute on Aging, Ricky Cott, who is the MSSP Program Director and Health Services Manager in the Aging and Adult Services Division with San Mateo County Health. And last but not least, Eli Weitzer, who is the President and CEO for Jewish Family Service of Los Angeles. We're really also pleased to welcome two Medi-Cal managed care speakers today, Edward Mariscal, who is the Director of Public Programs and Long-Term Services and Supports with HealthNet, and Liz Gaboni, who is the Chief Executive Officer with Partnership Health Plan of California. Next slide, please. So just a quick review of the agenda before I turn things over to Kate. We'll begin the start of the webinar with just some quick background on the current opportunity to improve care delivery for seniors and persons with disabilities in California and the reforms that are on the horizon, as well as some insights that were gathered in last August from different important voices that we had spoken with about factors that would influence the success of those reforms as they go forward. After that quick overview, we will hear from our LTSS panelists who will share forward-thinking insights that are important to building effective LTSS partnerships, but really thinking about that in a variety of areas that will be important for coordinating and delivering care going forward. And then we'll hear from both Ed and Liz, who are ready to offer some informal remarks after listening to our LTSS panelists as well as their own perspectives on what may be needed or encountered on the road ahead. And then finally, we will have some time for your questions and discussion and some conversation with the panelists. Next slide, please. So now I'm really pleased to turn things over to Kate Myers with CHCF.
Great, thank you so much, Alex, and welcome everyone. As Alex said, my name is Kate Myers. I'm a Senior Program Officer at the California Healthcare Foundation. And for those of you who may not be familiar with CHCF, we are a nonprofit philanthropy based in Oakland, California, dedicated to improving the way the healthcare delivery system provides care to Californians, particularly those with low incomes and those whose needs are not well served by the status quo. We were so pleased to partner with CHCS and Chapman Consulting on this work to explore the needs, challenges, and opportunities related to the proposed reforms to Medi-Cal under CalAIM that will impact the care of Medi-Cal seniors and people with disabilities. This was one of our first efforts in what is emerging as a new body of work at CHCF, focused on improving systems of care for older adults with complex needs and low incomes. This important work is part of CHCF's Advancing People-Centered Care portfolio, which broadly speaking aims to ensure that Californians with complex needs receive responsive, comprehensive, and coordinated services that support their health and well-being and reduce inequities in care. We all know that today's systems of care can make it difficult for Medi-Cal seniors and people with disabilities to get the combination of medical care and supportive services they need to stay as well as they can for as long as they can. There's a lot of potential for that to improve with some of the proposed reforms under CalAIM, but of course it won't be easy. And one of the critical success factors will be effective partnerships, collaboration, and coordination between Medi-Cal managed care plans and the organizations providing long-term services and supports in the community. Today, we're going to hear from both plans and LTSS providers, as Alex said, about some of the challenges and opportunities here, including what they've learned from past efforts to improve coordination for this population and how those insights can help shape this work going forward. So with that, I will turn it back over to Alex.
Thanks, Kate. Appreciate the opening framing and remarks. So if we go ahead and shift to the next slide, we're going to do a little bit of overview, and you can advance one more slide. And just really, start off by framing really the opportunity and the current moment that exists in California. And for California seniors and persons with disabilities, like the parts across the country, they face a number of obstacles and challenges navigating what is often a fragmented and I think well understood by California at many different levels of the healthcare system, fragmented and not integrated medical and long-term services and support system today. Yet California is uniquely poised to advance a number of SPD-focused reforms, most significantly those that are part of the California Advancing and Innovating Medi-Cal Initiative, or CalAIM, which alone would create significant opportunity to make statewide improvements in system integration and care delivery for all SPDs, including those that are duly eligible for both Medicare and Medicaid. Additionally, the state's commitment to a 10-year master plan for aging, which includes recommendations for improvement in integration and care delivery for SPDs, really contributes to the potential. There's opportunities that exist to assess how increased HCBS funding and flexibility at the federal level may help bolster these different efforts. And there's, of course, the existing models of LTSS coordination in California, of which there are a number, and also the models of integration in California that offer practical lessons that could be used to inform implementation of CalAIM and support Medi-Cal managed care plans and key LTSS partners as everyone is working together to improve care for this population. Next slide, please. So this just highlights, for those that may want kind of a quick snapshot of the proposed reforms that are on the horizon under the umbrella of the CalAIM initiative. You can see those here, and together, these reforms are expected to improve care over time for approximately 2 million seniors and persons with disabilities in California. The reforms include statewide mandatory enrollment of duly eligible enrollees beyond the areas where those individuals are currently enrolled in Medi-Cal managed care as a key step toward expanding access to integrated care statewide. The transition of the institutional long-term care statewide benefit to Medi-Cal managed care is another piece of these reforms that would see certain counties, particularly those that are not operating under the coordinated care initiative today or not operating as county operated health systems, shift to offering or being at risk for that benefit on a long-term basis. There are also elements of CalAIM, including enhanced care management and in lieu of services as proposed today, that would either have specific target populations or more flexible benefit offerings that will directly impact seniors and persons with disabilities. And then related to the first point here of, a statewide integrated option for duly eligible individuals, the transition of the California Coordinated Care Initiative, specifically CalMedi Connect, to an aligned DSNP and Medi-Cal managed care platform is slated to occur at the end of 2022. And alongside the other reforms, that is, of course, uniquely positioned to benefit SPDs that are eligible for Medicare as well as Medi-Cal. And then finally, CalAIM includes an equally important but longer range goal to create a statewide MLTSS benefit. And the recently published issue brief includes a timeline of these various reforms as they're currently proposed to move forward. Next slide, please. So this is the last area I wanted to kind of provide some background in before we hear from our panelists today. But there are a number of factors, and this is, of course, a snapshot and not comprehensive, I'm sure, others, but there are a number of factors that will really play into how these Medi-Cal reforms move forward and may influence Medi-Cal managed care's ability to develop that integrated medical and long-term services support vision for SPDs. And these factors that you see here were actually elevated by the Medi-Cal managed care plans and other key MCP partners that we spoke with last year. The left side of this list are key factors that may contribute to the flexibility that will be needed under managed care to really address the complex needs of this population. This includes things like flexibility and being able to tailor or target care management approaches, flexible payments under capitated managed care financing that would allow, the full continuum of care needs to be met. And then, those are, of course, both areas that the new enhanced care management and in lieu of services benefits are poised to support. Building statewide capacity to prevent or delay Medi-Cal institutional stays was another, key factor noted. And really, that is one where there's perhaps significant opportunity for providers and plans to be able to learn from one another in terms of replicating or tailoring successful care transition models in place in California today. And then another really important piece that I think recent, challenges in our world and in our healthcare systems with the COVID pandemic has raised, I think, significant light on is the need to address health disparities, particularly some of the underlying inequities that contribute to the different access to care, experience of care, and outcomes for seniors and persons with disabilities. And success in this particular area is really going to need to be defined, but it could include ensuring equivalent access to home and community-based services, as well as starting perhaps intentionally with applying an equity lens to important areas of program design, implementation, and downstream, data and quality reporting efforts. The factors on the right side here would actually be other important areas that may be more or less relevant depending on the kinds of past work or experience that both plans and provider or CBO partners may have engaged in as these reforms go forward. In order for duly eligible individuals to have statewide access to an integrated system of care that aligns with Medi-Cal plans and DSNPs as proposed, some plans will need to build newly found expertise and capacity around Medicare operations and contracting, along with developing integrated workflows for how they bring together what can sometimes be siloed Medicare and Medicaid plan operations. And then overseeing and developing networks to meet HCBS and social needs, along with refining or newly building long-term services and supports value-based payment strategies that really can help to kind of drive forward some of the goals of CalAIM, as well as individual Medi-Cal managed care plan goals, is going to be another really important consideration. So with that, we can go ahead and move to the next slide. And I am really glad to be turning things over to my colleague, Giselle Torralba, for the next, or our first panel. Thanks.
Thanks so much, Alex. Hi, everyone. I am Giselle Torralba, and as Alex mentioned earlier, I am a program associate at CHCS. I am so excited to hear from our LTSS panelists today, who represent a mix of LTSS provider perspectives, all focused on better coordination of LTSS for seniors and persons with disabilities as CalAIM opportunities move forward. First, we'll hear from Dustin Harper, Chief Strategy Officer at Institute on Aging. Dustin will start off today's conversation offering some insights around MCP and LTSS provider relationship building and contracting that draw from the Institute on Aging's extensive experience under the Coordinated Care Initiative, as well as his ongoing assessment of CalAIM opportunities on the horizon. Then we'll hear from Ricky Cott, the MSSP Program Director with San Mateo County Health, who will shift us in a more operational direction, offering insights on valued strategies used in San Mateo County to support data sharing and improve care coordination. Although the relationship between the MSSP site and the Health Plan of San Mateo is unique, there are definitely some relevant insights that Ricky will share that could apply more broadly as CalAIM work advances. Lastly, Eli Weitzer, the Chief Executive Officer with Jewish Family Service of Los Angeles, will join us to offer insights relevant to MCPs and LTSS providers as both parties consider how to work together to leverage new opportunities to expand HCBS delivery under CalAIM. Eli will draw from past experience and lessons under the CCI, as well as his forward-thinking insights on how to best maximize the impact of expanded community-based options moving forward. And just a reminder that questions can be submitted at any time through the Q&A feature at the bottom of your screen, and we'll address them during the moderated Q&A session after we hear from both panels. So with that, I'll turn things over to Dustin to get us started.
Thank you, Giselle, and thank you to CHCF and CHCS and really everyone who helped get this organized and get everyone together, particularly for this topic. I've had the good fortune of being in the LTSS and MCP relationship building realm for a number of years now. And, you know, it's an easy topic to quickly brush over or dismiss. But I think it's arguably really the core and probably one of the most important elements to be mindful of, especially on the front end of building some of these new partnerships. And I say that because, you know, relationship building is something that we all have perspective and experience around, but it's easy for us all to get quickly into some of the technical terms and some of the new proposed reforms and just trying to understand elements of it. When at the end of the day, what leads to success or determines success oftentimes is the level and strength of the organization relationships that are built between partners. And, you know, so that requires all of the things that all of our good relationships require, right? We have to work at it. We have to think of it as a relationship that requires nurturing, and we have to think of it at the organization level. There's a difference between having a champion at one organization and a champion at another organization that come together to work on a project. That's not a full organizational relationship. That's not a relationship at multiple levels with multiple points of contact. If a new CBO and a new MCP are coming together, it shouldn't just be clinical teams or the operations teams that are getting to know one another. It should also be the information exchange folks. It should be the monitoring and evaluation folks, and making sure that we have common understandings of our objectives and ultimately what success looks like. This is one of the biggest things, I think, for these new relationships to wrestle with out of the gate, is not just going into it with a let's try something out and see how it goes kind of mentality, but to be really explicit out of the gate as to what success looks like for both organizations, and making sure that the levels of commitment to achieving that success are equal on both sides. It doesn't work very well if a CBO or an LTSS provider is really committed, and this is going to be the most important contract in their wheelhouse, and the managed care plan has kind of just signed a contract and we'll use it if we need it kind of thing. Those types of relationships don't tend to pan out, and vice versa. If the managed care plan really has some lofty, ambitious goals and the CBO isn't fully on board with that, or there's a level of competing priorities there, that also doesn't tend to lead to success. So again, relationships are a key element here and not one to overlook. I think I put in here also around the commitment to value-based care and where it feels like that ties in here, because I really do believe that at the core of value-based care is this mechanism to try and align organizations around what they're trying to accomplish. And so the more that value-based care can, principles at least, even if it's not huge dollar amounts, even if there's not more than some of the fundamentals of value-based care included in the relationships that are being developed, that helps make sure that there aren't surprises and that ultimately a relationship doesn't end up working out, because we're committed to value, we're committed to measuring value, and ultimately to demonstrating the value of the services that are being provided. So a great place to start, and hopefully not one to overlook in terms of relationship building and contracting. I think also from a sort of technical assistance tips there, I really do believe that proposals that come from LTSS providers should include a hypothesis around the value that they believe their service or solution will provide. And if that proposal doesn't include that, I think it should be asked for by the MCP. And that can be a tool to make sure that there is indeed alignment around what success will look like, not just alignment around what services are going to be provided and when and the mechanics of the relationship, but really ultimately how we will determine whether or not something is successful. And ultimately, we would advocate for the level of information sharing that's required for that relationship to be consistent on both sides of the fence there too, right? So if there is data or health outcomes that are a part of demonstrating that indeed something is demonstrating value, then that should be information that both parties are looking at regularly and finding ways to improve on. I think kind of moving into the second question that the good folks at CHCS asked us to think about a little bit here. In terms of gaps in the LTSS system or capacity that some of these reforms could address, I think one of the things that's most exciting about these reforms is this opportunity to get to a more statewide consistent playing field and set of payers and risk across the state. It's been very challenging as a provider for the last 5+ years or however long it's been to have, I think, 7 counties in the state in essentially a different structure and different levels of readiness around LTSS compared to the rest of the state. And it's been a long time. And so those counties have gone, have charted a course, and they're in a different place from a readiness or understanding of the LTSS community than I think some of the other plans within the state. So it's going to take some time to get to a more common set of LTSS services and expectations across the state. But I think this the reforms feel like a potential step in that direction. And then, you'll hear me talk about value a lot probably. And, I think the LTSS provider community is particularly good at advocating for the needs of the populations of individuals that we all serve. One thing that we sometimes have work to do on is demonstrating the value of those solutions. And when we demonstrate the value of those solutions, it leads to more LTSS solutions. It leads to more individuals receiving those types of services. And so we really see that opportunity to demonstrate value, particularly with a healthcare payer that can align around incentives. That feels like a way to advocate for systems change. And so it's something that we're particularly interested in and mindful around, and something that we think that the reforms offer an opportunity for. And then the last piece here, I say highly customized solutions at scale. And so this for us is kind of the BHAG, or the thing that we are very interested to see if is feasible. Because from our vantage point, being a best-in-class LTSS service provider, part of what that means is having the ability to truly meet a very complex set of needs for a very individualized population. And yet there are a lot of elements of what I think we all would like, and particularly I think the managed care plans would like, to be at scale, and to have the health records, to have the reporting requirements, to have the privacy features needed, to have so much of what's needed to be successful and efficient, and ultimately bring down the cost of services. Some elements need to be at scale. And the LTSS community has always been very localized, and for good reason. How we collectively move to a system of care that both leverages some of those efficiencies and scale in a way that provides access to more services while not losing sight of that highly customized need and solution. I think that's going to be the ultimate measure as to whether or not these reforms are successful as we come back together a few years down the road and evaluate that. So I think that was the majority of what I was going to comment on here now. So I suppose, Giselle, if you'd like, I can pass it back to you or over to Ricky.
Yeah, no, that was great. Thank you so much, Dustin. So next up is Ricky from San Mateo County Health.
Good morning, my name is Ricky Cott, and I'm a Health Services Manager at San Mateo County Health, Aging and Adult Service Division, and I oversee the operations of MSSP and PFI, Partners for Independence. Our Partners of Independence program used to be the CCI IHSS program under CCI between 2014 and 2018. San Mateo County was one of the 7 counties which participate at CCI pilot. Currently, we're still working with Health Plan of San Mateo closely under the county CCI model. And thank you for allowing me to share with you our experience with Health Plan in improving the services to our CCI and MSSP client. As a disclaimer, because it's like we have a unique relationship with Health Plan of San Mateo, and then it may or may not apply to your agency, and then your relation applies to also to your managed care plan. The two factors that I think I would like to share is, which is important to us to establish data sharing and coordination strategy between MSSP and health plans and hotels. To me, is trust. One of the factors, trust. Trust is a very philosophical word, and then that's why trust doesn't mean just health plan believe in MSSP agency is capable to provide the services to our client, and then just by granting the MSSP contract to us. Trust also, to demonstrate trust, you also demonstrate the willingness to open your agency up to your partners in delivering the best services to the members or the client. And then I'm trying to demonstrate, trying to use a couple of examples to share with you how do we share information and data sharing. Before I started this, and then I would like to ask all the CBOs and then LTSS providers, how often do you run into playing phone tag with your health plan or Medi-Cal offers or the other CBOs, community partners? We always have phone tag because like you can't find the person, and then that's why you have to keep calling. The issue is like one of the first things that health plan open up is when we started CCI, they already give us willing to give us the space to station at the site. With co-locations at the same site, it allows us to just walk over to the specific health plan unit to inquire for information about the clients, to share information, and also to learn more about Medi-Cal benefits that health plan of San Mateo provide immediately so that we can meet the client's need appropriately and promptly. And then it's like, sometimes when it means it's like when we were doing phone tag, a lot of phone tag, that means delay of services to the client. With co-locations, we just walk there and then we share information right away. And then as for data sharing, and then there's another move that we always make, both agency made to, is we allowed each other programs to access to each other program database. And then that means it's like MSSP team staff have access to health plan program, database program applications. And we also allowed specific health plan staff to have access to our county programs too. And then what will it happen? So when we share, that means it allows us to analyze each other data freely and then to communicate. And then we use the information to develop program measures, objectives, planning for outreach, future projections of clients observed. And then it's like, that means it will help us to make more planning for the futures for the County of San Mateo residents. And then another thing is with access to applications, it will also save a lot of QA quality assurance issue too, because it's like health plan have access to applications, then they can look into care plans, objectives, care coordination context, progress note, and then it will be much easier for them to do all the QA tasks. The other factors I'm talking about is the partnership now. And then it's like, we established both agencies are committed to improve the quality of life of our clients. As a result, we are all committed to meet and at least annually in the client's interdisciplinary team meetings. It helps to share assessment information to identify clients' need and to develop care plans. And most important thing is it It will also help to determine our shared responsibilities, and then so that you can avoid duplication of services. In addition, since we are co-located, is other than the annual IDT meetings, we can always call for an as needed ad hoc IDT meetings if any emergent situations arise. It is different from previous MSSP programs that we just submit a care plan and then to health plan to review and then they give a decision. With all these communications, it will benefit more on how to serve a client much better and effectively and efficiently. I'm going to move on the second questions. Are there MSSP data sharing or coordination solutions in San Mateo County that over time could be put in place to help ensure success of proposal reforms? A minute ago, I was presenting a very nice, pretty pictures about how MSSP and health plan San Mateo work smoothly in serving our clients. However, it takes more than months, a couple of years of meetings, negotiation, compromising, and then to achieve to this current status. Currently, we still meet regularly to discuss about how to improve this process. And then it's like, so that we can have a better service delivery system. With the change of environment, change of COVID, we have to keep adjusting, and then we have to keep communicating with each other so that we can develop a consensus in all the logistic, all the process to service delivery process. And then the other things that I think I want to share is the expectations between a care plan, the health plan, and also a ECM providers, like right now is FTSS providers. It's very important because it's like in the beginning, and then we are not just submitting a proposal and then they approve the contract. There is a lot of standard work. There's a lot of workflow. There's a lot of documentation requirement, billing process. We have to be clear with each other because otherwise, and then it's like the first 6 months when we start the program, there's a lot of like denials and bounce back, and then we have a lot of back and forth communications. That's why in the beginning, we try to set the expectations, and then by writing it out, measurables, outcomes, and all the logistics, so that it can help to prepare a better and a successful implementation phase. Last but not least, and then it's like, we all know that all the health plan has different contract. And then it's like, and then they have different services for medical benefits for the members too. But contracting with MSSP is only one of the contract program. MSSP will not be capable to do everything, especially if you ask your providers to coordinate all the services. And then it's like, what we would like to know is health plan has to be willing to share with all the providers what kind of benefits they have, what contracts do they have, who are the contractees, who has the specialties, and then so that all these has to be closely communicated with the LTSS providers, and then so that we can update our services and contract providers' information, and then we can utilize those services for the client. And then these are the things that has to be opened, and then it's not like you just spell out in a contract and then it's like, oh, you just do all of this without enough resource, without enough information sharing, data sharing. The provider will not be able to do a good plan and then to develop a service deliver model. I think that I covers all the two questions. And then I'm going pass it back to Giselle now.
Yeah. Thank you so much, Ricky. That was great. And finally, I'm going to pass things over now to Eli from the Jewish Family Service of Los Angeles.
Thank you, Giselle. And thank you, Dustin and Ricky. I'm envious of San Mateo. I would love to work MSSP the way that you're working it. It sounds aspirationally wonderful, but I do think that there's a lot of room between how MSSP has functioned in many other counties and the San Mateo model that with the new ECM model, we potentially could achieve in working with health plans. So briefly, I don't want to repeat what's been said. I think that we've all had similar experiences around the importance of data sharing, really comprehensive data sharing and partnership around that. But I want to highlight a couple of pieces. The interdisciplinary care teams meetings work when they happen. They don't happen frequently, some plans really not at all. And they can tend to focus on compliance as opposed to on care planning. And I think that what we heard in San Mateo is that they can really focus on care planning and really deliver better outcomes and cost savings for the plans, better outcomes for the members. That's really the goal. So I think that in thinking about the ICT meetings, it's important, very important to recognize they're not just a compliance tool, they're really a care planning tool. That is their best use there. And in terms of care plan option needs, so in MSSP, providers have a small resource of funds that can be used for waivered services under MSSP. And under the CPO model, it's got to go through the plans. And so creating a streamlined process for documentation of need and approval process for care plan options. When that happens, it's great. When it doesn't happen, it's not great. And this is relevant to the ILOS services because they're going to be critical to meeting the needs of the individuals being served. And we have to make sure that the health plans and the LTSS providers are working together on a smooth, fast, effective process for getting approval of ILS services so that they can get to the clients. And in terms of where we really have opportunity, I do want to actually point out a couple of things. One is that the technical capacity of most CBOs in this sector is really constricted. It's the nature of the way that we're generally funded. And I think that when the health plans or the system, I should say, can really find ways to support developing that technical data capacity, it will really go a long ways towards creating a whole system of care that will be effective. Just briefly, I remember years ago when the LA County Department of Mental Health was implementing a new data and reporting system, and they provided direct grants to providers to help us improve our capacity so that really the systems worked in sync. And some of those grants were six-figure grants. I recognize that with Medicaid dollars, there are limits on how they can be used. But I think as a system, we would benefit from really some thought being given as how can the system really build that capacity on the provider level. As others have said, meaningful, timely data exchange is really valuable. We provide a lot of information. We rarely get data back from health plans. And developing effective ICT means are really valuable. So with that, I'm going to stop. I know that we're a little bit running behind on time and turn it back over to Giselle. Thank you.
Thank you, Eli, and thank you again to Dustin and Ricky as well for your comments in this panel. It was so great, and we really look forward to hearing more from the three of you during our Q&A session. But for now, I'm going to turn things over to Athena for our MCP Reactor Panel.
Have to remember to unmute. It's the world we live in. Thank you so much. Happy to be here and excited to introduce our next panel, which will be talking about some of their reactions to what they just heard from the LTSS partners. So I'll go ahead and ask Ed and Liz to turn on your cameras, and we'll go ahead and just get started. And we would just like to hear a little bit more about your thoughts based on your current and past experience on considerations for improving LTSS coordination as all of these reforms move forward. And then we'll also just ask you to highlight kind of 1 to 2 insights or lessons that you would elevate to your MCP friends as they prepare for the road ahead. So Ed, we'll start with you.
Thanks, Athena, and thanks everybody for your participation and partnership, especially over these last 13, 14 months as we've continued to navigate, but also learn from each other as we continue to move forward. So when we look at all of the priorities within our organization, and again, certainly don't want to repeat anything that the panelists had said earlier, but highlighting the partnerships and the creativity around some of these partnerships, the data sharing, the expectations. It's important that within these priorities in the LTSS community, we continue to align all of these partnerships. The speakers did a nice job of presenting these points. So let me focus on just a couple of areas where I think that the intersection of LTSS and managed care can really align to make these significant differences moving forward. And I think those two areas are in supporting our population experiencing homelessness and also our institutionalized population when we look at defining and measuring quality. Over the last few months, we've really, I don't want to use the word struggle, but um, with the population experiencing homelessness, I think we learned that the partnerships, the collaboration, the expectations, the data sharing was a challenge with a lot of our partners in some of these areas. And little by little, we learned to collaborate, we learned to care manage, and we learned to coordinate care with our community partners to better support this population. Um, we recognize often that managed care organizations are not the easiest entities to navigate through. We have a lot of entry points, and trying to identify that one person to help you is sometimes a challenge. So we on the inside have to really look at that and ensure that we are easily accessible um, to our membership, but also to our partners in the community. Um, and we have to continue to be creative with a lot of the services and a lot of the benefits that we provide. Especially when we look future forward, when we look at the great things that are going to come out of CalAIM, and Eli was mentioning ECM and ILOS, and that um, I think that gives us on the managed care side a lot of what we've been asking for or wanting to do over the last few years. We want to do more. We want to do these things for our partners and our members in the community to help them remain healthy, remain in their community for as long as possible. So when we look at providing these services to our members experiencing homelessness, and when we look at partnering with those experts out in the community that really do provide this support work, I think there's a lot of great opportunities that we have to ensure that we don't let slide by. And so that's going to include all of that collaboration, all of that partnership that we're starting to develop today. And so let me just say one more quick thing on nursing facility quality, because when we look at LTSS and when we look at moving forward with our community partners, and when we look at the opportunities through CalAIM, we see that pre-pandemic and during pandemic, I think we experienced a lot of different challenges when we looked at quality. Maybe we didn't focus on infection control as much as we should have 15 months ago. Maybe we didn't focus as much on staffing or discharges as we should have 15 months ago. So I think we have an opportunity today, in anticipation of the long-term care carve-in in the future with CalAIM. We have an opportunity to really be impactful, but really be better partners with our long-term care community statewide. And I think on the managed care side, we have the opportunity to lead this here with our contracting, with our ability to partner with facilities on admissions and discharges, on education, but also, and I'd be remiss if I didn't focus a little bit, at least, on equity. I like to say that managed care plans are the equity in the system. We are the equity in the system. We are the ones that are going to ensure that our membership, our Medi-Cal membership, receives equitable and inclusive care throughout all their levels. and we're going to build it into the CalAIM programs as we continue to develop. So to sum it up, we have an opportunity to be very proactive here, whereas I think we've been very reactive over the last few months, and really excited about the opportunities that are presenting to us at this time. So Athena, let me pause there, send it back to you.
Great, thank you so much. So really great feedback. So we'll pass it on to Liz for her thoughts on reacting to the panel and 1 to 2 insights that you would elevate for your MCP partners as they move down this path.
Thanks, Athena. Thanks, Ed. I did want to just remark on a few things that the earlier panel noted, which were really, really on point. Dustin, I appreciated his comments on evaluating the services that are provided through LTSS. And making sure that we can then scale them appropriately and that we're on the right track. And that's a continuous process. I liked how Ricky highlighted the need to have interdisciplinary teams that not just exist, but that meet and actually communicate about patients and members in common. And I also appreciated Eli's comments about not just for compliance, but ensuring data submittal that's timely, that's complete, that's accurate. Again, not just for compliance, but to actually improve the care and the communication around patients. But I think the overall theme that I took away from the panel is spot on, that it takes a lot of collaboration, a lot of communication, a lot of creativity and flexibility. And as much of these agreements go forward and all these different roles get hammered out, especially under CalAIM, it's important to continuously check and retool and improve as we go, because that we're in an environment that is definitely not static. Kind of as we look forward into the future, we're not a CCI plan, but we do have a long history of having long-term care services carved into our health plan for over 25 years. And we've also had a number of years running a DSNP program, which was very popular with our members. But ultimately, we had to close it down because the funding was inadequate, and we're not allowed to use Medi-Cal dollars to subsidize Medicare losses. So that is absolutely something that we need to ensure that we address going forward in the DSNP planning stages when we get a little closer. But more importantly, as we get very close to ECM and in lieu of services, we're thrilled about opportunities that are available to us. These are daunting challenges and tasks to set up the networks and to ensure everyone is ready to go, even in a staged environment that we're talking about with starting with the whole person care communities first. In our experience running long-term care services and trying to identify alternatives to institutional placement, one of the challenges we've seen over and over again, especially in rural areas, is just the lack of capacity for alternative housing and alternative placement. And so that takes those, housing and other resources take time to build. So it's really good to be thinking about this and working on this now. Partnership, along with many other health plans, have invested very significant dollars into housing, but capital projects take time to build, to get the approvals. And even if you're modifying an existing facility to provide congregate housing or room and board, it takes a lot of time to make those adjustments. So it is never too soon to start. That's not to say that even doesn't get at all the staffing that's necessary, which is my second point. And that is that workforce is so critical, again, even harder in a more rural environment. But the workforce shortages that we're seeing really have to be addressed. And there are many efforts underway. I'm very proud as a CHCF board member that CHCF is taking a lead with many other philanthropies on developing workforce alternatives for community outreach workers and others that will both help folks in our communities get employed, but also meet the needs of the healthcare into the future. So, I think there's tremendous opportunity, as has been said, under CalAIM and certainly under in lieu of services. It will take time to build this capacity, but I think the state is supportive of that and acknowledges that, and that we will take the learnings from the whole person care communities and the pilots and take the best going forward and establish new community partnerships with so many CBOs, as have been mentioned this morning. So I'm looking forward to it. I'll stop there, Athena, and I think we have questions, but I'll let you decide that.
Great, thank you so much. Really great information. Appreciate all the insights and the road ahead. So keeping with the road ahead theme, I'm going to have the other panelists turn their cameras back on so we can keep Liz and Ed in the hot seat here for a little bit longer. But we just wanted to kind of follow through on that theme of, what do you think the road ahead looks like, and what advice would you give, plans and your other LTSS partners? I'm going to start with Eli for some thoughts on that.
Well, I think that the road ahead is really has a lot of opportunity. And the reason I see that is because we've been doing pilots and demonstrations, and we've actually, as a state, learned a lot about how to make this integrated model work. I think now the question is, I'll be honest with you, is the investment in implementing CalAIM going to be sufficient and targeted well in order to really make it work? Because this is a huge system change, and we haven't perfected the system yet, this integrated model. So there's a lot of work still to be done, and it's important that as a system, again, that we're thinking about that all the parts and pieces have the sufficient resources to do the work the way it can best be done, and that will achieve incredible outcomes.
Yeah, that's great. Ricky, do you have thoughts on the road ahead and advice for your fellow partners or managed care plans?
I think I agree with Eli, but I think the issue is like, okay, we keep trying new initiative, which pilot, and then it's like, then we switch it, and then it's like, there's a better one, and then it's like, and then when you, to me, is even though we rename some of the, because it's like some of the name is different, we rebrand it, then, but the issue is like, the bottom line is we always want to have a slimness services for the client who meet the need. And then I think is like changing the name doesn't mean anything to me. I think is how can we continue to improve it? And then it's like, again, is when you're trying to coordinate all the service provider, because each service provider has their own specialties. How do we put them all together and work for a comprehensive plan for an individual? Because we always focus on person center, client center. But I think is up to the point that is like each CBOs who have a contract with the provider, have a care plan, has their own sort of like their own fragmented services. I think it's like we would like to see maybe the health plan take the lead in putting everybody under the same umbrella. And then how do we connect the dots is one of the things that I think we're still trying to perfectionize this, this task. And then, yeah. Thank you.
That's really helpful. And I'm gonna, actually it fits right with a question that we just got in the Q&A for, and I'm gonna kick it to Liz here first to talk about, when you partner with similar LTSS service providers, maybe across different, several different LTSS service providers, how do you make those workflows consistent, data sharing, care planning with all those different partners, or what are some solutions for that?
Yeah, it's best to do it up front if you possibly can. So if you go in and say you want to work with a meal provider, for instance, if you go in and say, here's what we're looking at, what we need, tell us what you provide, and the more consistency you can achieve and organize that up front, the best. But then again, you are going to need to have some flexibility as the program goes on to make alterations that make it work best for the member, and that can also meet the need of the CBO or the other provider. So flexibility, but as much as you can up front to be consistent is really possible. And that helps with evaluation as well.
Very good point. Ed, from your perspective?
So I certainly don't want to repeat Liz's point on flexibility and being proactive, because that is the correct answer, of course, but also understanding that 3 months down the line or 6 months down the line, you might have to pivot again, and that's okay. We're not going to have all of the answers immediately. That's why we try to bring in, as Ricky pointed out, bring in the experts, bring in the providers, Let them tell you how they have been doing it successfully for so many years. And then let's identify the best practices, the lessons learned, and move from there. Again, with the understanding that 3 months later, you may have to completely pivot again, but that's okay. It's going to be fine as long as folks like Ricky and his team and Eli and Dustin are the ones there doing the hands-on work, really caring for this population. We're going to be fine. Maybe my workflow has to be redeveloped. Heck, if I just have to do a new workflow, then it's been a good day. You're doing all the hard work.
Yeah, so it sounds like a combination of sort of upfront expectations, but then flexibility, the name of this whole year and all of these processes that are coming. So that's great. And Dustin, I'll just have you kind of comment on this question. I know, IOA has several different, services it provides, so sort of thinking through how you partner with plans for those different services and maybe partner with other community-based organizations.
Yeah, I mean, I was struck by something Ed said earlier around, the competing priorities within the health plan that are even really outside of the LTSS realm, right? And so as I think about the road ahead, one of the things that I wonder around is, the LTSS community is very excited about the prospect of this moment and the politics of this moment and what COVID has done to the awareness around LTSS services. And yet the health plans have a lot of things on their plate besides LTSS as well, right? And so we shouldn't lose sight of that. And yet I think I also, I want to ask the LTSS community, and I think I want to ask the plans a little bit to also, we need to organize ourselves a little bit, right? We can help be part of that organizing function for the plans, and it still needs to come with the upfront expectations and the flexibility that you're talking about there, right? But to the extent that the plan's limiting factor is how many of these relationships they can manage and how many of them they can do in a way that feels successful, I think it's on the LTSS community to look at ways to organize ourselves in a way that can be a little bit easier to partner with.
That's really helpful. Lots of learning and opportunities here. So speaking about sort of building those relationships, what I heard is sort of a theme throughout everyone's comments is this idea of building relationships and, having that it takes time, right? And it's got, there's sort of no substitute for, really building not just that, one-to-one, two champions within an organization, but across a location, across organizations. I think Eli, you mentioned co-location. Ricky talked a lot about, outcomes, right? How do you actually, agree on what outcomes and measure those? So there's so many pieces to that sort of relationship commitment and then building. So, is there any way around that just taking years and years to build? Or there, sort of best practices or ways that you all have found that within your organizations, you've been able to build up that capacity? And I will start with Eli again and see if you have any thoughts on that.
Thank you, Athena. So I think that the first step, and everybody on this call certainly recognizes this, is that it's how we frame the relationship. I like to think of it as collaborators rather than vendors, collaborators in the positive way. And because we do have those relationships with some health plans where we're a vendor and we provide what they want from the vendor, and that's the relationship, but that's not where we want to get. So that's the framing piece. And then in terms of all of those other pieces, I think particularly initially, frequency of meaningful meetings around developing processes and planning is the way to get there. And we did see this initially with MSSP, that with some health plans, we had frequent meetings and then they became less frequent going on. We didn't need them as often, but that I think is a way to begin to build the trust, the knowledge of each other, the learning from each other, what each other needs, and the relationship building pieces that Dustin was talking about that will then allow all those other pieces to flow from that.
Great, really powerful. We'll go ahead this time to Ed to answer that question. I'd like to hear more about that relationship building.
Thanks, Athena. And so when we look at relationships with our partners, we look at creativity. We look at what we do best, but we also look at what we can possibly do or what we want to do for the population that's within our scope. Because there are always other things we can do. There are other connections we can make, but there are also other partnerships that we can bring into the conversation, into the situation to help the overall outcomes. I said earlier, it's okay not to have all of the answers, and we're not always going to have all the answers, but we can bring in those outside resources to help supplement whatever we don't know or whatever we can't do. On the managed care side, we also have sometimes we have some flexibility with some funds to be able to pay for something or provide something. And sometimes I'm surprised by how much it's not utilized. Other times I find myself offering it and it not being accepted. So there's a push-pull there sometimes. Depends on the situation, depends on the resource, but the creativity that we can bring into the partnership, or the creativity that we ask of our partners, I think is a really good way to continue to improve outcomes.
Thanks. And Ricky, I'll pass it to you, especially since you have the MSSP health plan relationship that I think was envisioned under the CCI and that had a lot of challenges across the state. So any insights you have on that relationship building is really helpful.
Well, when I was sharing with everybody, that's why I can only say as a disclaimer, our relationship with health plan is unique because one is we only have a single health plan in San Mateo County, which is sometimes I feel for my partners is like who have to deal with so many different health plans, and then maybe have different, because once you have different health plans, you may have slightly different expectation from different health plan. I think it's like, and then that's why I think the so-called the inconsistency or the struggle is there now, because as a provider, I have to piece this health plan expectation and the other health plan, and then the third one health plan, especially in LA County. I know it's like clients move from one region to another region. And then I think relationship, it takes time to build. And then I think when health plans started to offer the co-location, it's already started with open arms theory to us. Oh, you are welcome. It's not like, oh, you're just another contract provider. And then because it's like, it shows us that they really want to make this partnership work. I think it's like, sometimes we have to learn. And then again, it's like there are a lot of pull and push. Then it's like, and then it's so that we can compromise. But I think it's like in the beginning, the first 6 months, almost every other week meeting, and then every month, and then every other month, and then quarters meetings. And then I think it's like, it takes time to build that. And then it's not just right now. And then sometimes it's like, we decided to have, okay, let's have once a quarter meeting now. And then I think it's the demonstration of willingness to share. Because sometimes the difficulties is you have to maintain your own division identity versus health plan is whether you'll be part of health plan. That's why sometimes it's how much you're willing to open, how much can you share with also HIPAA issue too. There are a lot of things that you have to consider, but I think is with consistent communication and understanding of each other, sharing the expectation, I think it will help down the line. Thank you.
So following on that, Liz, you're also a single plan in the county. Do you have experience that's similar or some more to share on that?
Yeah, I think that what that reminded me of was really the importance of freely sharing best practices with each other. That's one of the first things we do is we check with our local health plan comrades and say, okay, we have this issue or this challenge. How have you done it, or have you done it? We even look to other states. And I think that's one of the things, the strengths about CalAIM is that DHCS looked all over the country for successful models and incorporated bits and pieces from other states. And I think we should freely share with one another. If something's working, let's look at it together and move it forward at a larger scale. So hopefully folks won't be too proprietary about that.
Yeah, that's great. And Dustin, do you have any quick thoughts on that relationship building from your perspective?
I would just add simplify, and I think it's easy for us all to get caught sometimes in, I think, minutia of we don't agree on the interpretation of what an encounter means or some regulatory guidance or things along those lines. And when we get there, we sort through it, but get back to the fundamentals of simplifying it, build something that's valuable, figure out how to measure it. The other pieces will fall into place if you can get those elements front and center and keep them front and center.
Great. Well, thank you so much, all of you. It's been really great. I wish we had more time. I have a lot more questions, and I actually see one in the chat that has to do with financing and value-based payments. So I don't think we have time to go down that path, but more to come for sure. Lots of things that are exciting, and really good to hear from all of you about kind of where you've been and where you hope to go. And we really thank you all for your time and all of your insights today. So I'm going to go ahead and hand it back to Alex and to close it out. And I think there's a little survey for you all to do. So thank you so much.
Yes, thank you so much, Athena. So glad to be able to be part of this and hear all of those really helpful insights today. And I want to thank our speakers for their contributions and the valued perspectives that you offered. Hopefully it will leave folks who joined us today or folks who listen to this, at a later time with some, practical areas that really need to be explored as all parties work together to both increase understanding, but build the capacity that's going to be needed as these opportunities and reforms move forward. Two quick things. One, Athena mentioned, which is you should have seen a pop-up survey opportunity. And so before you grab lunch or otherwise move on with your day, if folks could take a moment to respond to the evaluation, that would be great. And then we will also at CHCS send an email to all registrants about, the slide posting and the recording availability as soon as that, that is up and running. So thank you again for joining us, and hope everyone has a great rest of your day.